Welcome, everyone. Thank you so much for coming to the research review today, and thank you for choosing to come to my presentation here. My name is Rachel Rice, and today I will be talking about eosinophilic esophagitis, otherwise known as EOE, food allergies, and the RD's role in treatment. Before I begin my presentation, I would just like to ask how many of you have ever heard of EOE, either in your personal life or in practice? I just am kind of curious to see how much or how many of you have ever even heard of this disease. So it's kind of not known by many people, I feel like. So if you could just want to type in the chat yes or no. Okay, so you guys have heard of it. That's great. So I had never heard of it before until my brother was diagnosed with it a little over a year and a half ago. This is my brother Jake. He is 18 now, but when, like I said, a little over a year ago, he got a piece of meat stuck in his throat, or so he thought, and it was so stuck that he could not even swallow his own saliva. He was walking around the house with a cup, and he would have to spit in it because he couldn't swallow saliva. So he ended up going to the emergency room, and they did a scope of his esophagus, and it revealed three things. The first was that his esophagus was about 6 millimeters wide, when an average person's is about 16 millimeters. And as you can see on the bottom picture on the right there, that's a pretty big difference. And the second thing that they discovered was that his esophagus was covered in eosinophils. The third thing was the doctors told him that he would have to be on steroids for the rest of his life. So today I will be giving you a little introduction of what EOE is, the current treatment strategies used to help patients with EOE, and then the research I studied, and then finally how this applies to the RD and what we can do to help patients with EOE. So EOE is a very new disease. It was first named in 1993, and since then it has been growing a lot in the US especially. The doctor that my brother saw said that he sees about 30 patients a day, and this is just in Milwaukee County that he sees all EOE patients, and so I just thought that was amazing for a disease that I've never even heard of before this. The healthcare costs are about $1.4 billion a year in the US. And something that I thought was a little interesting is that it's 3 times more common in males, which they're not really sure why, maybe some type of genetic variable. EOE is an autoimmune disease, and what's happening is the patient is allergic to some kind of protein in food, and it causes inflammation and causes these white blood cells to line the esophagus. And the problem with this disease is that the allergic reaction is not the normal way that people are allergic to food. It's not the normal mediated IgE immune response. And so you can't do the skin prick test or skin patch test to find what foods they're allergic to. And this creates a problem. It's diagnosed by if they have 15 eosinophils when they super zoom into an esophagus, the lining of the esophagus, and if they have esophageal dysfunction. So what is an eosinophil? It's a type of white blood cell, and they help defend against mucosal pathogens. They are pro-inflammatory, so they help respond to tissue damage and tissue remodeling. And they also regulate other immune cells, such as B, T, and dendritic cells. So they do a lot of great things. However, when it comes to EOE, they become a problem. So this picture kind of describes what's happening. The allergen is ingested either through the airway or in the food that they eat, and the allergen gets ingested into the epithelial lining. And the allergen causes an allergic reaction. The helper T cells think that it's a foreign invader, and they in turn recruit the eosinophil to aid, and that causes the inflammation. So I thought I would include these pictures because it really helps show what these EOE patients are going through. So the first picture up on the top, the A, one's labeled A, is showing the rings that can form, and the bottom pictures that are noted severe really show how severe this can get. And so with my brother's case, he did have the rings, and this really is what makes the esophagus diameter so small, and it also causes more food impaction. Food gets very easily caught on these rings. The second picture is just showing the white lesions that line the esophagus. The third would be, so the pictures that are labeled C are showing the furrows, and so you can see those lines that are going vertically down the esophagus. Up on the top right, on the top row, you can see the vasculature, so you can see all the blood vessels pretty easily. But then in the bottom row, where it says severe, there you can no longer see the vessels, and this is showing the edema that can form. So the severe swelling, and this also is what causes the throat to be so tight and constricting. And then if we jump down to the bottom right corner, the pictures that are labeled F, you can see how fragile the mucosal lining is in the esophagus. And so this is probably a picture of someone's esophagus after they had their esophagus stretched. And my brother recently had his esophagus stretched, and the pictures look very similar to this. So you can just see how patients with EOE have all these things going on, and this really limits their ability to eat normally. So the symptoms are what you may think: vomiting, choking, dysphagia, food impaction, and acid reflux. And unfortunately, there is no cure as of right now. There are 3 treatments that patients can take. The first is steroids, and these are steroids that are given to asthma patients, and instead of inhaling them, they are just given the liquid form. My brother takes these 3 times a day, once before every meal, and it kind of just coats his throat. The second is protein pump inhibitors, or antacid. These have not really great results. They're supposed to help with the inflammation. They're supposed to help reduce the eosinophil count on the esophagus lining, and also to help reduce the stomach acid so that it's not coming up and burning the esophagus further. However, if you think about it, they're reducing the acidity in the stomach, making it more basic, and the acidity in the stomach is what breaks proteins down. And if a patient is allergic to the proteins in food, and the proteins aren't getting broken down because their stomach acid isn't acidic enough to do it, those proteins that they're allergic to are sitting in their esophagus and stomach longer and causing more of a reaction. And so they don't have really great results, and doctors have to prescribe about 8 times the normal amount that people are given for it to even see any effect. The third treatment is dietary therapy, and you might be thinking, oh, this is where we come in. This needs a little bit of work. The first option is to do an elimination diet, and this would be cutting out the first or the most common allergenic foods from their diet. So this is dairy, wheat, eggs, soy, and fish and nuts. And then they would cut these all out of their diet for 6 weeks, and then reintroduce one, and then go and get a scope done of their esophagus, and then reintroduce another one and go get a scope. So this is very expensive, because to get a scope done of your esophagus is about $20,000 a piece. And it takes a lot of time because you have to introduce one at a time very slowly. And it's super restrictive. You're cutting out 6 major food groups out of your diet. The second option is to go on an elemental food diet, and this would be pretty much to cut out all proteins or food proteins. And so basically a patient would go on tube feeding formula for the rest of their life, or as the doctor told my brother, he could go on baby food for the rest of his life. So these are the options that patients are left with, knowing that if they don't go on any treatment, they could get esophageal cancer, or they could lose function of swallowing in their esophagus. So this is where we come to the question of what is our role as an RD in treatment. The first study I looked at was looking at the elimination diet. Instead, they did a step-up version of it. And so their objective was to determine the effectiveness and resource saving of a step-up strategy for empiric elimination diet in pediatric and adult patients with EOE. And I chose this study because I wanted to know if, number one, there was any success with the elimination diet, and number two, if there was a better way to do it. This was a prospective study, which means that they watched a cohort of participants over a period of time. It was done in 13 Spanish and 1 Italian outpatient clinics or endoscopy units. There were 105 adults and 25 pediatric patients, and the researchers noted that they had this amount of pediatric patients, so it was 1 to every 4 adults. A participant was eligible if they had EOE according to the agreed upon consensus guidelines. If they had a lack of history of response to an 8-week trial of the anti-acid therapy, and if they had never been on a steroid or dietary therapy before. They were excluded from the study if they had any gastrointestinal disorder, if they had eosinophilia different from EOE, if they had any severe allergic reaction to milk or wheat, if they had the inability to adhere to an elimination diet, if they had any esophageal varices or active anticoagulant therapy, or if they had severe fibrostricting EOE, so if they had severely constricting esophagus. And so all patients from the study were put on a 2-food group elimination. So all participants eliminated dairy and wheat from their diet, and the dairy included goat's and sheep's milk, and the wheat also included barley, rye, and oats. And they noted that they did this so that they cut out all possibilities of cross-reactivity. And so they cut all these out from their diet for 6 weeks. And then they were given written instructions for accurate and adequate reading of food labeling so they could avoid foods containing hidden names for milk or wheat. And they were advised to avoid as many processed foods as they could and given a thorough list of foods and sample menus. So the participants who did not respond to this were then put on a 4-food group elimination diet. And they cut out of their diet eggs and legumes in addition to the dairy and wheat. And then if they didn't see any response, they were put into the 6-food group elimination, and then they eliminated nuts, fish, and all other kinds of seafood from their diet, in addition to the other 4. Any patients who did not see any treatment or did not see any remission after these eliminations were put on steroids. And so here are the results. At the top, you can see 130 patients went through the 2-food group elimination diet, and then 56 patients, which is 43%, achieved remission. And I think that's amazing. 43% achieved remission without going off of all 6, but just going off of dairy and wheat. Then you can see that 54 patients decided to keep going, and then of those patients, 10 achieved remission. And then another 27 patients decided to keep going, and 8 of those patients achieved remission after eliminating those 6 foods. So in all, 57% of the patients who started the step-up diet achieved remission. And of those 57%, 43% achieved remission just after eliminating the 2 foods. No differences were seen between the pediatric and adult patients. They both responded the same to the diets. And this research was in line with what I had been seeing in other research, stating that milk and gluten-containing grains and eggs are the most common food triggers. And then they also noted that legumes were the next common. And in the US, they see it to be soy, which was also included in the legumes in this study. The step-up elimination diet is better than doing the highly restrictive elimination diet, I think, because number one, it early identifies the triggers with only having to do 1 scope instead of having to do 6. And it includes diets that are easy to follow in our culture today, because gluten and dairy-free diets are very common in our culture. The diet saved time and money because, number one, they didn't have to do as many scopes and they didn't have to keep going in to get those done. And then it was also very manageable for them to try because it was less restrictive. Some strengths of the study were the number of participants. It was a good amount, as well as the fact that there were pediatric and adults included in the study. Their inclusion and exclusion criteria were very thorough, and they excluded many possible confounding factors. However, the study does pose some limitations as well. Since it was conducted in Spain and Italy, it may not be an accurate representation of EOE patients in the US. And they did not include the same number of adults to pediatrics, so the pediatric patients may not have been represented accurately. There also was no washout period done between endoscopies, so that this is not proven that they need to do this, but just because it wasn't included in the study, it may lead to misleading results. And lastly, the results are dependent on the participants' compliance and honesty with their diet restriction. However, despite these concerns, this study poses a new way of conducting the elimination diet in a way that is more manageable and less restrictive for patients. The second study that I looked at was titled Food Allergen Triggers Are Increased in Children with the TSLP Risk Allele and Eosinophilic Esophagitis. Their objective was to investigate possible correlations between the TSLP risk allele polymorphism and epithelial responses to food antigens. This study is totally different from the last one, and it was pretty much looking at how the genotype relates to the disease and if it has any connection. This was performed at the Children's Hospital of Philadelphia. There were 309 pediatric participants between the ages of 0 and 18, and all of them had EOE. They were excluded if they had any gastrointestinal diagnosis, if they had not had any success with, if they had no antacid treatment, if they had limited medical records, and if they had no scopes done to identify their food allergen triggers. And also if they didn't have any food allergies noted. Participants were analyzed for food allergies using the elimination diet and multiple scopes to figure it out. The participants were then and this was the TSLP SNP that was previously identified by researchers that I had looked at, and they kept finding that EOE patients have this common risk allele. So this is the SNP that they studied. Additional data was reviewed, including atopy, which was defined as having one or more of the following, so asthma, allergic rhinitis, or eczema. And they also evaluated the participants to see if they had any IgE-mediated food allergies. So this is the usual, they get a skin prick test to see if they're allergic to these foods. The results are very interesting. They found that 83% of the patients had a TSLP risk allele. And of those patients, 37% had 2 risk alleles and 46% had 1 risk allele. I think that's just amazing that 83% had this risk allele. They all had EOE and 83% of them had this risk allele. Another fact that I thought was interesting is that 82% of those that had this allele were males and 91% were Caucasian. This graph just shows how many food allergens were found in the patients who had the risk allele versus the patients who didn't have the risk allele. And so patients who had 2 or more food allergens, 85% had the risk allele and 56% didn't. This is another interesting thing that they found. They took 12 different cells from these patients, and so 5 of them had 2 risk alleles and 7 had 1 risk allele, and they found that the cells from the patients who had the 2 risk alleles had significantly enhanced TSLP response to OVA, which is the major protein found in egg whites. So this means that OVA was actually able to directly induce the epithelial cells in the esophagus to secrete more TSLP, which is a immune response reaction, and it was able to secrete more in the patients who had the 2 risk alleles. So because the patients who had 2 risk alleles, they found that more of this TSLP, which causes more inflammation and such, was produced in those patients. So these results give us future hope of being able to use genetic testing to treat EOE patients based on their genotype. This could help reduce the cost of multiple scopes patients have to endure to figure out what they're allergic to if they can eliminate something based on their genotype. For example, if someone with 2 risk alleles could eliminate eggs and milk from their diet right away and then get a scope to see if there's any remission after, it would help them reduce the restrictiveness seen with the elimination diet, and they wouldn't have to get as many scopes done. Of course, more research needs to be done before any of this could happen. Future research could focus on treating a patient based on their genotype and then maybe follow them throughout their treatment for a more prospective study design rather than retrospective. This could help future RDs in guiding the patient to eliminate the correct foods from their diet and help the patients find foods that they can enjoy in a faster and easier manner. Some strengths is that large-scale study to correlate the TSLP genotype with the phenotype in pediatric patients with EOE. It also did a good job of analyzing many variables such as food allergies, asthma and eczema, the genotype, and specific risk alleles, meaning that if reproduced at a larger prospectively studied population, it could be important in helping the physician determine what is the best treatment option for an individual patient. Some limitations of the study is that it was retrospective, which means that it only provides evidence to support a future prospective study. Another limitation was that the researchers did not specify what percentage of the population were of different ethnicities. They mentioned that 91% who had this risk allele were Caucasian, but they never mentioned at the beginning what percent were Caucasian to begin with. But this article brings about so much excitement at the future possibility of being able to use genotyping as a way to treat patients with EOE. The last research article I chose to study was about birch pollen. The objective was to observe the effectiveness of using CRD, which is component resolved diagnostics, to characterize sensitization patterns in adult EOE patients. And I actually came across this article while I was researching what foods had the same proteins as carrots. And I was researching this because Jacob, my brother, has always had a problem with carrots. His esophagus always swells shut whenever he eats them, and he always chokes on them. So I wanted to know, so I figured that he's allergic to them. So I want to know what proteins have the same, or I'm sorry, what foods have the same proteins as carrots, because he's allergic to the protein. So I kept coming up with this thing called oral allergy syndrome. And this is basically where people who have seasonal allergies, for example, to like ragweed, they also have a cross-reactive allergies to foods containing the same proteins. The seasonal allergy that kept popping up with EOE patients was birch pollen. And so this is what this study evaluated. This was done in the Netherlands, and there were 76 EOE patients recruited. They each were asked to do a questionnaire evaluating in their personal or family history. They then had a blood sample taken, and that was then analyzed using the specific machine, and it was used to measure specific IgE antibodies against 112 different food and aeroallergen components. And this is the system that they use, CRD, component resolved diagnostics. And basically, as this picture shows, it's taking the allergen, so for example, peanuts, and it's breaking it down into its individual specific allergy components. So a person is not allergic to peanuts, they're allergic to the specific protein in it. And then it looked at other proteins in foods that could cross-react to that protein and cause the same reaction. So they found 80 different components in 59 patients, so that's about 78% of the participants. And they found that these patients were predominantly sensitized to molecules present in grass pollen, tree pollen, and house dust mite. In total, about 494 sensitizations to these aeroallergens were found. So that's about 8 sensitizations per participant. They were also able to detect cross-reactivity in 30 patients, which is about 39%. And something that is interesting to note is that all 30 of these patients were sensitized to birch pollen. This table shows the results for one participant. So as you can see in the first column there with the food, the apple, nuts, and peanut, that is what this participant self-reported his food allergens were. And then the second shows what the CRD, so the component resolved diagnostics, came back and said he was allergic to. So you can see that it confirmed that he was allergic to nuts and apples and peanuts, and then it also verified that, or gave him peaches as another thing to look out for. So this study highlighted the CRD system, which provides a more detailed insight into sensitization patterns in EOE patients. This study was able to confirm the widespread aeroallergen sensitizations to grass and tree pollen, house dust mite, and cat and dog. Many people have said that sensitizations to food allergens in EOE patients are because people have these allergens to grass and tree pollen and cat and dog. And this study was able to kind of confirm that it's because of cross-reactivity to these items that they're allergic to the foods. A limitation of the study is that it was not systematically compared to a skin prick test or a patch test, just to see the differences between them and if they came across any similar results. It was also dependent on the patients filling out the questionnaire honestly. However, the study was able to provide insight into the sensitization patterns of EOE patients, additional food allergen sensitizations, and could be useful to help direct individualized dietary therapy in EOE patients. So this brings us back to our original question of what is the RD's role in treatment? What can we take away from all of this research? Last week, my mom was super discouraged, and I asked her what was wrong, and she said that the doctor had just called and gave her 3 options for treatments for Jacob. He said that he could stay on steroids, but instead just increase the dose. 2, he could stay on the steroids, but then he could take 8 times the prescribed amount of antacid. Or 3, he could go on the elimination diet. And without any action, he told her that Jay could lose his ability to swallow, or he could get esophageal cancer if the esophagus is damaged any further. And so patients and families are coming across these huge decisions like this. While they want to do the elimination diet, it is so daunting to families and patients, and it seems so impossible to follow because you're eliminating 6 major food groups out of your diet. It is also very costly and time-consuming to have to go in every 6 weeks for a scope. What patients and families need is help and to see that there is a way to do it. Our number one job as an RD is to support patients in getting the nutrition that they need to live a healthy life. For patients with EOE, this means supporting them throughout their journey to remission of EOE. This will be informing the patient and helping them work through the options. Tell them about the elimination diet and even the step-up elimination diet, and how they can just start with 2 food groups instead of all 6 at once. Give them examples of what a meal plan could look like. Show them that it is possible with a bit of perseverance and planning. Show them that you are there to assist them in any way they need and that you are cheering them on for success, whatever that may look like for them. Maybe in the future, you can inform them of the option of doing a genetic test to help distinguish food allergens. And lastly, ask patients if they have any seasonal allergies or if they notice any foods that are consistently causing them reactions and inflammation. This could lead them to meaningful food eliminations without having to do multiple scopes. Lastly, stay informed on future research. EOE is such a new disease that doctors and nurses are learning more about it every day. But it is up to us as well to stay informed on topics such as these because they are directly related to a patient's ability to get nutrients. To the EOE patient, life is full of foods that they no longer can eat. However, our job as an RD can be to show these patients all the foods that they can eat. Our goal should be to find a treatment for each patient according to their needs, and together, you and your patient can find a way for them to once again eat the foods that they love. And that brings me to questions. You guys have any questions for me? And then here are my sources.
Thank you, Rachel. That was really awesome and a great presentation. Hi, everyone. My name is Lauren, and I'm one of the other dietetic interns helping out with the event. And I just wanted to hop on here really quick before Rachel started answering your questions. So if you don't have any questions, feel free to leave this meeting room and take a little break before our final presentation, which is at 11:35. Also, Flora has put in the chat box the link to an evaluation that we would really appreciate if you took a couple minutes today to fill out to give some feedback to Rachel about her presentation. But other than that, if you have any questions, feel free to ask away.
Okay, so I see a question from Kathleen that says, is it necessary to scope after each step of the diet, or will the symptoms resolve? The problem is that patients aren't really able to tell, at least my brother isn't able to tell when the inflammation and eosinophils are reduced, I guess. And so far they haven't really been, no matter what he tries. He hasn't really tried any dietary therapy until now. I have him off of all of these foods that have the same proteins as carrots. So he has a list on the fridge of foods that he can't eat. But yeah, that's the problem, is that patients can't really feel when they're in remission. So yeah, good question. Yeah, he doesn't really notice any change right away when changing his diet. So I try to get him like, okay, when you eat this, like, do you feel your throat closing? Is it swelling up? But it's not really so significant. I think probably part of the reason is that his throat is so small already, that he's lived with this probably since he was 8 or 9, the doctor said. So he's kind of just used to it. Any other questions? And I see that Beth noted on the oral allergy syndrome. I was so excited when I found this because my dad is allergic to ragweed. Is really, really bad allergic in the fall, and he has had really problems with, like, when he drinks milk or eats eggs. He can't eat melons, and it was kind of, he didn't know why. And then I found this, and like all of the foods that are have the same proteins as ragweed are the foods that he can't eat. So I was like, oh, this is why this is happening. And I just thought that was super cool, and I kind of geeked out there for a minute.